I don't have any disclosures. Here's a slide I put in that actually I think is going to fit pretty well right now, showing the kind of grand overview of the competing technologies for BPH therapy. And like some of you recognize, like there's Superman over on the right. There's that purple dude down front. I don't know who he is. And this is the ever-going flow of the new technology as we start to move, I think, a little bit more away from medical therapy and a little bit more towards procedural therapy. Just at the last AUA, we saw the first randomized controlled trial showing superiority of an interventional therapy over medical therapy in terms of sexual outcomes. I think that was actually a pivotal point in sort of the arc of BPH care, however you do it. And I think for all of us, we're just going to hit the club that we swing best, right? Like we're going to use the technology that works the best in our hands for our patients. I clinically practice at the VA, the Rocky Mountain Regional VA. We did the first aquablations in the state. We do Rezūm, we do UroLift, we're doing Optilume very soon. We do all of them. They're all great, and it really is the pleasure of kind of picking the best one of these guys for each of your patients. And then there's always like this guy comes along next on the technology front, and you're like, I don't know, is this aquablation or Optilume or whatever. TURP, which I'm charged with talking a bit about today, is really the James Bond of all the different treatments for BPH. Can't fly, drinks a lot, but at the end of the day, he gets it all done. I mean, he's just the absolute classic treatment for BPH. These are the learning objectives. We're going to talk a little bit about these few different outcomes in terms of TURP specifically. But backing up a little bit, you can say, you know, why are we all here? Why are we having a giant session with these very impressive experts on BPH? It's because it's a huge problem. This is the sort of picture we all saw. I took this as a third-year resident at Northwestern and ran back home to get the tennis ball for comparison to show, you know, what BPH can do. And when you step back and look at BPH on a global level and on a national level, the impact on medical care practices, if you're budgeting for a large healthcare system, the impact of BPH is absolutely enormous. We wrote this paper just a couple years ago, but it exceeds all cancers on a global level in terms of how much it impacts a healthcare system. And in America, it's a very similar sort of curve and far more than any other urologic process. So this is, to a large extent, the motor that keeps the lights on in everybody's offices. As a fun sidebar, if you track looking at the green curve there, that's men over 65 global. Blue is men over 65 US. I don't know if that arrow is showing up. Yes, it is. And down at the bottom in the gold, we see US urology workforce trends. So there's a lot of them and not too many of us. And this technology that we're looking at is incredibly important as to how we do it, why we do it. And doing things that work well and last is ever more important also, as opposed to medical therapy. I did a little bit of math for one paper I was writing that we spend in America more on BPH medical therapy than the defense budgets of all but 3 countries on Earth. Like, it's an insanely expensive process to treat. The IPSS score, I think, is a surprise to nobody here. We use it a lot at the VA. It functions as almost a fishing expedition for the guys that show up with a kidney stone and have an IPSS of 25 and think it's just due to growing old. We'll talk a little bit about it. So briefly, how much benefit do you find from medical management for BPH? And when you look by alpha blockade, 5-alpha reductase inhibition, anticholinergics, PD-5 inhibitors, you know, it's a few points on average in a well-designed, randomized, controlled trial, but it's not all that much, ultimately. The AUA guidelines now suggest that you can move right past medical therapy to things that actually work, which is the surgical and MIS options, which we're all talking about here today. There's a ton of them. You see them right here. That picture at the bottom is from some guy's ad in Australia. I don't know how he thought that would induce anybody to come to his office, but apparently he did. But when you look at the outcomes, and if we just look at IPSS improvement in terms of points decreased from pre-therapy to post-therapy, TURP, what I'm here to talk about at the top, but all the others down, these are wildly different than medical therapy. These procedures actually work. Great improvements in flow. The side effects that you saw with all the medical therapies from, things as concerning as psychologic side effects, erectile dysfunction caused by the medications, et cetera, are gone, you do substitute other different sorts of issues. But the take-home from this slide is that therapies, these invasive and minimally invasive therapies, actually really work. So TURP versus sexual function, and this is the hot topic of 2024, it seems, in 2023 and 22. Retrograde ejaculation is seen 70%, 80% of TURP series. So gosh, you know, we're not going to do that anymore, right, because that's become incredibly important. Well, actually, you can do, as was just briefly mentioned, with photovaporization, an ejaculatory preserving TURP. There are a number of series that's published showing this. This is one of them. The sort of pericollicular apical tissue around the ejaculatory ducts is what matters to preserve antegrade ejaculation during TURP. You can do this. It's not hard. You just leave 5 to 10 millimeters of tissue above the viru and do the rest of your TURP the same way that you always would. These are the results from the trial I just showed, or the study I just showed. This is the only picture. They chose a bunch of different ways to try to show you the same thing, but this is the viru, obviously, and this is the margin of where the TURP is, just a little bit upstream. Again, as mentioned before, you're not going to tell every single patient that they're going to ejaculate antegrade, but you can do this, and it really does work. Secondly, another benefit of TURP, and this I think is just worth discussing, not many treatments of all these options, except HoLEP perhaps, generate tissue. So you're not going to necessarily get tissue anywhere else. And if you're worried at all about somebody with prostate cancer, then TURP provides an option for you to take a look, learn a little bit more. The truth is that it's very rarely beneficial. In most big series, this is a very recent, very large data set. It's only 2.2% found incidental prostate cancer, and less of that was clinically significant. Screening, I threw this in just kind of for interest. These are the biopsies by year, starting about 2010. We're biopsying before TURP less and less and less. MRI has gone up a little bit before TURP. But at the end of the day, the incidence of prostate cancer incidentally found on TURP remains extremely low, and the great majority of them, 2/3, don't get any treatment. That's probably less than should get no treatment. Catheter time with TURP actually generally these days with bipolar TURP is low. There are good comparative trials between monopolar and bipolar favoring bipolar substantially, and I suspect that few, if any, in this room still do monopolar. But it's worth noting that having a catheter really matters to men. We talk in our group to men about how long do you want to have a catheter, and if we propose to somebody, you can have a catheter overnight and a general anesthetic and a 30 or 45-minute operation, versus you're going to have a catheter for even just 3 days, much less 5 or 7 or more. A lot of times I'll say, put me to sleep, let's do it once, let's get it over with, and not walk around like John Wayne for the next week. Many of the other technologies do afford very brief catheter times. Prostatic lift, certainly at 0 days, is worth noting. The water jet a day or two if the bleeding has stopped, et cetera. And that summarizes it. First of all, TURP can still be an absolutely excellent modality. The urinary outcomes are great. Sexual outcomes can be great if somebody says, as may very well be the case, gosh, I really want to preserve antegrade ejaculation. You can do it. From a training standpoint, for me as a program director, you know, we did aquablation. It's great. I love it. It works. It's a terrible teaching procedure because it's so quick and relatively simple and technique-free. With TURP, you can get tissue, and literally everybody in this room, with the exception of our one urogynecological colleague, and with apologies, can do this right now. Thank you very much.